All right, so we are live. Good evening, y'all. It's yours truly, Dr. Pierre. Welcome to another edition of the Real Physician Reacts. This is our weekly live stream where we just touch on topics that just come across my social media feed. And I was hoping, right? I had the mindset because I saw this tweet earlier in the week about this medical student who was deciding, you know what? I'm not doing this medicine thing no more. I'm foregoing residency. I'm not gonna do the residency. And I was all ready to talk about that tweet. Like I was ready to go. But then lo and behold, a video hits my feed, my TikTok feed of this cardiologist that I follow. And it was a response video from a nurse practitioner who was responding to a comment and just started absolutely going wild. Like that video is wild. Like I will, it was worse. I tried to look for the video. The video's gone. In fact, her account's gone too. Hopefully that account didn't get deleted. That's what I'm hoping, that they didn't delete that account. Hey everyone, thank you for joining. Thank you for joining. Make sure you like, make sure you share, because I think this is going to be a good one. So we are going to be talking about this battle, right? And I put it in quotation marks. This battle of the NPs versus the MDs. Now, the title of the live, I had to throw in the DOs in there too, because a lot of times, like the general public just says MDs, and I know they meaning doctors, but you know, when you're a DO, you're like, hold on, what about us, right? So I knew we were getting some of that fire too from that video. But I just wanted to make sure that y'all knew that, like, in the MD versus NP quote-unquote battle, like, make sure you include the DOs in that battle as well, too. So we're going to be talking about it. So I just want to kind of give the premise of her video and why I like some of it, but why it went off the complete deep end. And let me preference this. Let me preference this in case someone catches on late. This is not an NP hate account. We love NPs where I'm from. Not only do I love NPs where I'm from, I train NPs. I work with NPs. In fact, as I speak, I have 4 NPs under my care, taking care of my patients. So we love NPs here, right? But like, I think there's some discussion that needs to be had because, unfortunately, you know, let's talk about this. You know how when you're talking amongst family, you can say stuff amongst family, but when the folks outside of the family hear it, all of a sudden they may construe it in a much more menacing way. Like that's what happens, right? Like amongst the doctors and NPs, we have this discussion, this ongoing discussion, but we're not really supposed to let the general public into our family discussion. Unfortunately, that NP's video let the general public in, because she got a lot of people following her, into the general discussion, right? So I feel like as a physician, like I have to touch base on it because it was just like it was all kinds of wrong. So the video initially began, and again, I will definitely link Dr. Sayeb's, I think is his name, Dr. Sayeb, MD. I'll definitely link his account so you can watch that video, so you can see the video that I'm referring to, where she's just one kind of explaining that, you know, as an NP, she is a doctor. She has a doctorate degree, and you know she has the right to take care of patients. So I think we should start there, because I think the general public typically sees when we talk about healthcare system, we know there's doctors. And we know kind of in the hierarchy, right? And I say hierarchy is just kind of the way it goes. There are, they're not even, I don't even want to call them, because they're not even mid-levels, right? But we'll just call them NPs, PAs, right? Kind of boom, kind of under. And then, especially in a hospital setting. And then you have your RNs and it just kind of trickles down. So you have this instance where, depending on the state that you live in, a nurse practitioner may have a lot more rights and a lot more freedom to do a lot more things versus other states. Like that just is what it is. I'm in Florida. I believe they have full practice rights here in Florida. They may need some, signed off, but I think they have full practice rights. And I think New York is another one. And there's a few other states where they just need, where they don't need necessarily physician supervision. Now, when it first came around, this is 1960s, when it first came around, that was the case. And you've probably heard content creators talk about this before, as far as like, why did we even get to the point where we have nurse practitioners and physician assistants? Well, just like we're dealing in 2023, in 1960 we were dealing with the same issue as far as having a shortage of physicians, right? Like myself, to get into the primary care world, right? Because specialties have started opening up, and more physicians were subspecializing in different specialties, which left this void of people in the community who needed to have a primary care physician, but didn't have it because there just wasn't enough. Now, again, fast forward to 2023, we are still dealing with that same issue. So this is not a new concern, a new problem as far as the lack of having primary care physicians in the building. Not a new issue whatsoever. So what happens in the 1960s, they say, hey, you know what? We need to enlist more help and more support for the communities that are going to need it. So in the mid 1960s, you had nurse practitioners, that give birth. You had physicians assistants that gave birth. Again, this 1960s, all kind of same time frame. And it's been this kind of push and pull issues kind of throughout, right? Where, again, just like when you got a child, right, and you birth that child and that child starts growing up, child wants more responsibilities, right? So that's what kind of started happening, is that, as the profession became more regimented, more official, more credentialed, everything under the sun, they started wanting more responsibility to do so, and they got it. So let's fast forward to this nurse practitioner and her video. Her video kind of, again, starts off saying, hey, yeah, I'm a nurse practitioner. I have a doctorate degree in being a nurse practitioner. I take care of patients. I think she's like an ICU trained nurse practitioner. So she takes care of a lot of patients in the ICU setting. Now, again, when you're talking with Dr. Barry, we're all good here. Like, I'm right with you. Hey, thank you for joining. Thank you for joining. Make sure you like, make sure you share. Where the conversation starts going on the deep end is that then she starts laying into the field of internal medicine. Now, if you know, right, especially if you're new here, make sure you hit the follow button. She starts laying into the field of internal medicine, which, again, Dr. Barry is an internal medicine physician. So, of course, now my ears are perked up, right? Because I'm like, what's she about to say about internal medicine? She starts going in on how internal medicine is on the bottom of the totem pole, and that all of the subspecialists look down on the lowly internists. That was like she was like, nah, like, while y'all here, let me tell y'all, like, we don't even really respect the internists the way we like. And mind you, when I hear that, it's not a new thing, right? Remember, I kind of talked about how y'all when we have family business, you're not supposed to let the outside know. When I was a medical student, around my medical student friends, they would talk about it, but they wouldn't talk about it in regards to just internal medicine. They talked about it in regards to primary care, because what typically was seen is that those who went to primary care were seen at the bottom of the totem pole. And when we say bottom of the totem pole, a lot of it was in the eyes of pay, because it just is what it is. And, we can go on a whole discussion on how people get paid in medicine, but those who do like me, like who educate, who talk, who say, hey, this is what you need to do for your blood pressure, your diabetes, your cholesterol, your COVID, like, the insurance doesn't necessarily pay for that. What they do pay for is when I go and I do a procedure. What they do pay for is when I do a surgery. What they do pay for when I do something with my hand, something technical, or that requires like a facility, that's what they pay for, or they pay the most for. So just the education, the discussion, you're not going to get that much. You're not getting that type of money. So when you think about that, think about the specialties in primary care where a lot of their focus is on educating and trying to, again, veer you away from getting downwind and causing problems. So naturally, guess what? The primary care fields got the lower pay, which is why, again, since the 1960s, we're in the issue that we're in now, where you have more and more healthcare professionals, especially medical students, deciding, hey, you know what? I can't even go into primary care because I got so much medical bills, medical student loans and undergrad student loans that I can't even afford to do it. A graduate student too, I can't even afford to go there. So you have more and more people, which again, still happens to this day, go into these subspecialist roles. And in their mindset, because pay in their mind is attached to hierarchy, they feel that because the pay is lower down here, that people look down here at those who are down here, which again, typically internal medicine, family medicine, pediatrics, like those are the three specialties when we think about it of the lower paid. And mind you, y'all already know me, especially if you follow me. When I say lower paid, it's very relative, right? It's a very relative term when I say low paid. So I don't want people to be like, oh my God, y'all doctors make da-da-da-da-da. Fam, I know, I understand. So, but when I say low pay, I'm talking in a room full of doctors. So let's make sure we get that clear. So here you have this nurse practitioner who goes off, talks about how, yeah, I'm a nurse practitioner, I'm doctorally trained, which we agree with, which we understand. Congratulations. But then when you veer off into the road and you start talking about how everyone, like all of the specialists look down at the lowly internal medicine physician, and even her example made zero sense because she started talking about how a patient who may be critically ill, how like if you're just an internist, because that's what it was, if you're just an internist, like they would rather have a nurse who's trained in several nursing related specialty, right, for that patient. Like that was her premise. It was like, I don't care if you're a doctor, like I'd rather have a nurse who has all this training and everything else. And mind you, again, I'm an internal medicine physician. I take care of a lot of critical patients. I'm very comfortable in the ICU, right? Very comfortable in the ICU. Hey, Heather, how you doing? So, of course, right? And again, of course, it's coming from a position of a lack of knowledge, right? And more just kind of painting this wide casted blanket on the field of internal medicine. But again, right, there's a little truth in it. Not the truth that internal medicine are looked at a low to total pole, but that there is this conversation that people tend to look at primary care on the lower ring, right? And then what typically, what she follows up in conclusion, hey Millie, how you doing? What she follows up in the conclusion is that it's not even an MD versus NP thing. It's a MD versus MD thing. Like we're having some the doctors are having, and again, she says MD, I'm a DO, so I'm assuming she's included me as well. But the doctors are having an internal battle amongst themselves, and they don't really have anything to do with the nurse practitioner. So let me tell y'all, full disclosure, there are a lot of doctors here who don't really like nurse practitioners. Like, full disclosure. So I won't even like lie to you and act like all the doctors love nurse practitioners and physician assistants, and like I won't even lie to you and say that. In the same breath that there are a lot of, I don't say a lot, there are some nurse practitioners who don't really like doctors, right? Who feel like, Why do I need a doctor to do? I can do just as well or just as good as a doctor. Like there's some who really think that. And again, I'm not here to kind of argue, whether you can. I got my own. I tell you, I don't think they can. I think if you're an internal medicine trained physician versus an internal medicine trained nurse practitioner, I think the internal medicine trained physician is going to do better because of just the amount of training. It just is. When I compare apples to apples, like I'm pretty confident that the physician can do it. But again, that's not the case. And again, it's usually a nurse practitioner discussion, right? Because like I said, I train with physician assistants as well. And this does not seem to be a battle that physician assistants are dealing with, right? Or even have. Like the PAs versus MDs. That's not even a title that you even hear. Right? It's always NPs versus MDs. Like that's always this thing. And again, it's one of those things where, you see your child grow up, right? Because again, doctors founded NPs, right? There were doctors who said, hey, we need more people to help the primary care world, right? The communities. Let's build this program up. So the same ones who founded PAs, physician assistants, founded, and not the same people, but like, again, that same ilk. So there should never be some animosity if your number one goal is taking care of the patient. But what you see time and time again, especially those with that type of mindset on both sides, with those with that type of mindset, is that like they don't really care that the end result is maybe a patient's getting well taken care of. It's all about them. It's all about their personal stature in the world, and they want to feel better about themselves in that ilk, right? So it's always no, I'm better than this, I'm better than that. And as a physician, as an internal medicine physician who, again, I've done, 4 years medical school, 3 years residency, I've been practicing. Like I have a lot of training just in the field of internal medicine. We know that there is less training for those who want to become a nurse practitioner. We know that that it's less, I want to say regimented, right, as far as the path it takes to become a nurse practitioner. That's just like common sense. Like there's no discussion, there's no argument. But just because there's less doesn't mean that they get less, that all of them are bad. Like that's not the case either, right? Like I said, I work with some amazing nurse practitioners and PAs, absolutely phenomenal. But like, so when you're having this discussion and you're trying to have this like tit for tat, like, oh my God, I'm much better than any MD, especially when especially when she was, shitting on the internist. I'm like, oh, come on, what are you doing here? Like it just spoke from a level of ignorance that of course my fellow colleagues are going to jump on her. Like I said, I went to go check her account. Her account's gone. So I'm hoping that she just like, deactivated. I'm hoping they get that girl deleted because I don't want her to get deleted. Right? That doesn't make any sense, right? Because again, she's a nurse practitioner. She takes care of patients. Again, the end goal is the patients, right? So we don't want our caretakers to like feel like they can't voice their opinion. But when your opinion is based, right, in doo-doo, right, you should be able to be like, all right, like I hear the criticism. And like, I understand why I might have veered off, right? So again, I'm hoping, right? I think the ad name was like Dr. Jackie Reed or something. So I'm hoping that she comes back. I'm hoping that she was just able to like temporarily deactivate, let the storm kind of, die over and then come back. But again, it was disheartening to see that because one, it's not a new argument. It's not a new discussion. But again, as we go through this pandemic, as we go through, and again, the workforce is still needed, right? We're still gonna have physician shortages. We're still gonna have physician burnout, right? We're gonna have more and more physicians continue to lead the workforce. And if we're having more and more physicians need the workforce, we need people to, again, take care of the patients, take care of our loved ones in the hospital, in the rehabs, in their communities, doing home visits. We need all of that to happen. Like, this is a battle that in 2023, we should not still be fighting over, right? We should not still be fighting over whether NPs, right, are better than MDs, right? Like that should not be a discussion that we're still talking about in 2023. But unfortunately it is, right? Unfortunately, we're still here, still battling. And it's a sentiment that like it's still being held true, that people feel this way. And again, like I said, and again, I may be totally wrong, but I never hear this from physician assistants. I never hear this from physician assistants. Oh, thank you, I appreciate you. Thank you, Coach G. Thank you, I appreciate that. I just never hear this from. So it's always the nurse practitioners that are having this battle of, I don't want to say supremacy, but I'm not sure if it's trying just to establish a level of credibility, because y'all got it. Like y'all, that's it. Like I hope in 2023 we aren't trying to discredit the work and effort of our nurse practitioners and physician assistants, right? I hope in 2023 we also aren't trying to discredit the work of those who went to medical school, went to residency, finished all 3 boards and are practicing. Like, I would hope in 2023 we still aren't having these discussions, because what happens is that it blinds us, right? And it allows us not to focus on the real. I don't want to say, I hate to call them enemy. We're not going to call them enemies. But I think some of the real problems out there is, and again, I you know, y'all know me. If y'all follow me long enough, I'm very straight to the point. It's all about that dinero, right? And I think you have physicians who are upset that they aren't making the money that they think they should be making. I think you have our nurse practitioners, our physician assistants, who may be upset that they aren't making the money that they should be making, right? Like, no one thinks they're making enough money. No one thinks they're making enough money. Trust me, ask anyone in any job, but especially in healthcare, no one thinks they're making enough money. But we shouldn't be fighting amongst each other. That's like when we start picking on the waitresses and the people who work at the bar and saying like, oh, why do I have to tip these people? Instead of being mad at an industry that pays them like $2 an hour and literally forces you guys to subsidize their pay with tips. Like, that's what we're doing. We're fighting over the chicken scratch. You have insurance companies, hospital industries making billions of dollars a quarter. Billions of dollars a quarter. And here we go again, nurse practitioners, physician assistants, again, in fact, I'm not even going to include them because we don't have that discussion. Nurse practitioners and doctors like arguing over semantics and pennies. Like, that's what we're doing here. Okay, let me go follow up with some comments. We do not want to leave our comments behind. Again, I appreciate everyone on the live. Make sure you like, make sure you hit that share button, and obviously, more importantly, make sure you follow. Yes, Heather, I am a DO. Let me give a shout out to Heather. Heather does an amazing live Saturdays and Sundays. Perfect. Amazing live Saturdays and Sundays on long COVID. And she brings some amazing people to give personal stories that I love to see, especially just as a human being, but just as a physician who's taking care of patients with COVID. And to kind of see, because I'm in a hospital, I don't typically see like the after effects when I've saved them and they're long gone. So she does an amazing live. So she's definitely someone for you to follow. But I'm a DO. I went to Nova Southeastern University here in Florida. I think now we have a hospital. The school's name has changed because we had a big donate some money. I think it's Kiran C. Patel. In fact, Kiran C. Patel Osteopathic Medical School. Let's see here. Favorite doc, JC showing love. I appreciate you. Let me see here. So this is the point here to me. Tracy, Tracy, I believe. It's scary. It's scary to think that we have nurse practitioners with this mindset that like, oh no, I'm better than, my supposed supervisor. Because again, depending on the state that you live in, a lot of nurse practitioners have to work under supervisor. And again, it's not all states. It's not all states, but there are a lot of states where a nurse practitioner has to work under supervisor. So imagine you working under someone and your mindset every time you walk in isn't like, wow, let me go take care of this patient. It's, man, I know I'm better, right, than my boss. A lot of us think we're better than our bosses, right? So it's an okay feeling, but to kind of fester that and let that build inside you, that's bad, right? And then, yeah, Guardian Angel 94, let's highlight her. She talks about how there are terrible doctors and terrible NPs. Exactly. So the fact that we know that there are terrible doctors, terrible NPs, terrible PAs, terrible RNs, terrible PTs, like there's terrible people in every specialty. So to try to have some type of alliance where you're like, oh, no, I'm only rocking with the MDs or DOs, or I'm only rocking with the NPs and PAs, right? To have that type of alliance makes zero sense in the world. And especially, and again, this is one thing that I always have caution with for my nurse practitioners, and especially those who I work with, and I'm friends with a lot of people in the nurse practitioner field. My biggest gripe is that there's no uniformity to their level of training, right? In terms of how do you go from being a regular Joe Blow to become a nurse practitioner? There isn't any like one step body. There's not like a body that says, hey, this is the path you need to go. Like for me to become an internal medicine physician, I got to get a bachelor's degree in the United States. I got to get a bachelor's degree. I got to get a medical degree. I got to pass not one, not two, but 3 national board exams. And then I got to go to residency. I got to go to residency for 1, 2, 3 years. After that residency, I didn't have to pass another national board exam. Boom, now you're an internal medicine physician. Like, I have to do all of that. I can tell you that path that I just talked about does not have to occur for nurse practitioners. And even when it comes to doing rotations, it's not like they're saying like, oh no, you have to have rotations with a doc who sees this many patients. No, it's, hey, I need a person who does OB. Can you shadow? Boom. Can you, hey, you're a pediatrician. Can I shadow you? Boom. Like that's the level of competency that occurs, right? Now, again, once they're done all of that training and they get to this, our side where it's time to work, we train them up. Like, we train them up very well. So, especially if you got good ones, right? Because remember, terrible doctors, terrible nurses. So we train them up very well, hopefully. But like what they have to go to get to the point to get trained very well, again, it could be a little sketchy, and that's usually my only knock against them. But like after that, I'm like, hey, rock out, right? If you've done the work, you've passed the board exams, minus that, those couple of schools in Florida, right? You've done the work you need to do to get here. Now it's my responsibility as your supervisor to make sure I give you all the tools necessary to take care of the patients in front of you. Right? So it's we're supposed to be a team. So, but when you keep having infighting amongst the team, guess who suffers? It's not the physician who suffers. Guess what? They still pay me for being a physician, right? Whether you think internal medicine are dumb or not, I get paid very well. Right? But it's the patients who we're supposed to be, again, the goal, take care of patients. Those are the people who always suffer, right? And that's what it always hurts me, because I'm like, look at them. We got to do this again. Lines are going to be drawn again, and the person who's going to suffer is the patient, right? So again, just yeah. Oh yeah, the header says this best. Less ego with the MPs and PAs. I think and that's again, doctors need it too, but like when your field of training, the goal of it was to be under a supervision. Again, I'm not lying, right? The goal of it was to be under the guise of the hierarchy, right? You can't then be mad when at the end you're under the guise of the hierarchy. You can't be mad if, and this is something where, obviously I try to work with my patients, because this is more of a educational thing that I think the nurse practitioners, the PAs need to work on. especially nurse practitioners, right? Especially if it's a doctoral degree, right? You want to be called doctor? Sure, go ahead, rock out. Like no one should be able to take away the degree you work for. So, but y'all got to do a better job at educating the public. So when you say, hey, I have a doctorate, right, an advanced doctorate as a nurse practitioner, go ahead, say that. Like, because we know that if I just get on, like if I got on this slide, right, like for example, username, Dr. Pierre. If I never let you know that I went to Nova Southeastern University, I went residency at Columbia Hospital, 3 years. If I never say those things, you're going to assume I'm a doctor of medicine and I went to a medical school and you're going to assume all those things. But if you just say Dr. Pierre, but then it takes someone to find out like, oh, you're a nurse practitioner? Like the general public's going to feel bamboozled, and you can't be mad when the general public calls you out on that feeling. That's you not letting folks know like, hey, like, yes, I have a doctoral degree. Yes, it's a nurse practitioner, but I take care of a lot of patients. Like, there are so many different ways that she could have responded that would have had her video just like, oh, okay. But the fact that she went in, said, yes, I'm a doctor. I have a doctorate in nurse practitioner. And by the way, the internists suck. Like, once you go off the deep end, like, what can we do for that? Like, nothing we can do. Let's see. Oh, this is a good question, right? So, and this is Angel again, Garden Angel. I feel MDs deals feel threatened by PAs and NPs. No, let me show you what I think is the issue as far as the threatening. There's not an industry where, like, there's not a specialty, right? Who feels that, man, if I don't do what I need to do, this NP is gonna take my job, right? Because and that's still, that line of thinking makes zero sense. If you're in any specialty where your bosses, right, your hospital settings can replace your position with a nurse practitioner, you should not be mad at the nurse practitioner. You should be mad at the system. Right? That's, again, like, it's just one of those things where, we're mad at the waiters because they need a tip to survive, but you're not mad at the system that is forcing those waiters to only get paid $2 an hour. So I don't think it's an issue of doctors feeling threatened. And again, I know you included PAs. Honestly, this is not a discussion we be having with PAs. Like, very rarely is this conversation of physicians versus and they're not called, I'm using the term mid-level provider because that's what it started out with. They're not mid-level providers. Before someone like hits me in DM and says like, please don't call us mid-level providers. I know y'all don't go by that term no more. But in this discussion, just so when I say mid-level provider, I'm meaning PAs and NPs. Because again, if you search mid-level provider, guess what's going to pop up? So in this discussion here, it's not an issue of the doctors being mad at the mid-level providers or feeling threatened by them. They're upset at the system in general. And guess what? The easiest person to hit is the person you have to punch down on. And right now, again, hierarchy-wise, we punch down, right, on the PAs. It's not really PAs. We punch down on the NPs, especially when there's a mindset from those, again, lower than you on the hierarchy that they should be in your spot. But again, I hope, especially for my docs who will be watching this, is that, again, and we should, focus our energy. We got to focus our energy on the right people. It's not, like, for example, I think the best example is the anesthesiologist and the nurse anesthetist. There are, for those who may not know, you get surgery, you have to go to anesthesia. There are certain hospital systems where the person putting you under is a nurse anesthetist. Now, I'm not saying that to assume that the nurse anesthetist does not have the proper training to do so. I'm just letting you know that that's what it is. Now, what typically happens is you likely have a anesthesiologist who may be supervising, just like I supervise. You may have a supervisor physician over the nurse anesthetist. I'm assuming. I don't think that you have nurse anesthetists that are running solo, but again, maybe in some of these states, maybe that goes down. But if you ask the general public, would you rather have an anesthesiologist trained physician versus an anesthesiologist trained nurse to put me under? We all know who the public is going to say. We don't have to beat around the bush about that. Like, we don't have to be gullible about that fact, right? If we're talking about the general public, we know what the general public feels. So it's the reason why you may go around and just call yourself doctor, but not let people know you're a nurse practitioner, right? Because you know that the general public, and because there hasn't been enough education, may not understand that, hey, just because I'm a nurse practitioner does not mean that I can't take care of you, right? So I think that's what it is for sure. Let's see here. Oh, this is a good one. I feel that some doctors don't take time to listen to the patient, unlike some NPs and PAs. So I like this fact, right? I like this statement because it talks about just the training and the upbringing of the profession. In the medicine world, right, it's typically very analytical. It's typically, okay, what are the signs, the symptoms? What are the things happening? Okay, give me diagnosis, give me treatment. Boom. But if you're, let's say if you're, I'm not going to include PAs, but let's say you're a nurse practitioner and you're training as a nurse. Before you start a nurse practitioner, you had to become I'm assuming you had to become an RN, a registered nurse. And a lot of that training in registered nurse is all about the bedside manner. So your focus was on making sure that you had great bedside manner. And to have bedside manner, guess what you got to do? You got to talk, right? You got to listen. And you go and become an NP, guess what? It's not like your training kind of went away. So you may still have a great ability to listen and talk to your patient, especially in the bedside approach, than physician colleagues who maybe their primary training is like in the hospital setting. They're go, 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 go. I tell people all the time, like, I started out in outpatient medicine. And for those who have an outpatient doctor, you know that the doctor you're with, they got to talk to you for like 15, 20 minutes, sometimes in half an hour in a closed room, just like I'm talking to you right now. So imagine how comfortable I am being able to talk to the internet, because I've had the training to be able to talk to someone one-on-one for 15, 20 minutes. So of course, if I go around in the hospital, that patient's going to feel a little bit more comfortable when I'm talking, because they can just sense that, oh, you know what? I like this doctor right here. Like, all the time. Like, I just round in the hospital. All the time, patients are asking me, oh, do you have an office? Can I follow you up when you get outside? Can I get outside the hospital? And the look of disappointment when I tell them, oh, I'm sorry, I only round in the hospital, so I don't actually have an outpatient clinic, is because they can recognize that, this doctor that's in the hospital, he's different. So I agree that there are going to be some, especially for my, again, mid-level providers, again, don't shoot me, right? Please don't shoot me if y'all catch the replay. The replay will be available on YouTube tomorrow. Don't shoot me if a mid-level, it doesn't surprise me if a mid-level provider has a little bit more empathy, a little better bedside manner. They feel less cold. So I actually like that comment, because I think low-key, I think that's kind of true. Don't tell all the doctors I said that, but I think it's low-key kind of true. I'm an exception for a lot of different reasons, but I think it's because I started out in outpatient medicine, and more importantly, I like talking. And because I like talking and I get on social media, it's so much easier for me to not only talk, but it's easier for me to explain, and it's more importantly, it's easier for me to listen. And because I can do those things, and I know for a fact I do them better than a lot of my colleagues, again, not to toot my own horn, it separates me from others. So I low-key, not in general, but I can see why that take is extremely important. And shout out to Millie. We love Millie here. The thing is that healthcare is a teamwork, and that's what it is. This is such a team effort. I personally round at 4 different facilities. I could not personally round at 4 facilities without the help of my nurse practitioners. I just couldn't do it. Like, that's the reality that we live in. I could not do it without my nurse practitioners. And there's a lot of doctors out here who could not do the work that they do without mid-level providers, nurse practitioners, PAs, like RNs, especially if you're in a hospital setting, RNs, the PTs, the RTs, the OTs, right? Shout out to my environmental service. There's a lot of people who we could not take care of our patient if we were not acting like a team. We just could not do it. The CNAs, again, I forgot. I hate that I almost forgot my CNAs. Shout out to the CNAs. Y'all know the work that y'all do. Shout out to the CNAs. So it doesn't make no sense to kind of have this continued, back and forth and acting like we're adversaries, right? Because no one wins from that standpoint there. Let me see here. So I think this is a reference to NPs. They have to go to college, then grad school, and take boards as well. Yeah, like so do my PAs, right? So imagine, right? So imagine if you have to do all of those things there, and then at the end, when you're done doing it, you start talking to those who also had to do that, like they are at like the bottom of the totem pole. Especially, and this is, I can tell you one of the biggest gripes that you will hear from the doctors in regards to mid-level providers. Again, mid-level providers. Y'all, if y'all on this live, y'all know who I'm talking about. It's the fact that I can be a mid-level provider. In the year 2023, I could be in the specialty of internal medicine, doing a great job. And in the year 2024, I decided, hey, you know what? I don't want to do internal medicine no more. I'm going to do cardiology. I apply and boom. Now I'm in the field of cardiology. Yep. In the year 2025, you know what? I kind of like surgery. All right, boom. Now I'm in surgery. So if you're a physician, I can't go from 2023 being internal medicine physician to 2024 being a cardiologist, to 2025 being a general surgeon. Like, I can't do that. And if I told you I could do that, like, how much level of expertise would you actually, like, believe that I actually have if every single year I have the ability to just kind of jump specialties? So that's one thing. Like, if I had to pick, boom, out of the sky, something that the doctors typically, when they are, quote unquote, looking down on the mid-level providers, is because they understand that they have the ability to go from specialty to specialty to specialty, especially because the pay is usually better. It is what it is, right? The pay is usually better. So they have that ability to go from specialty here, specialty there, and then be like, okay, all right, I'm done doing this field. I'm going to another field. And that right isn't afforded to those who are in, like, again, let's put me in, for example. Like, I like cardiology, love cardiology, actually. It was one of my favorite subjects in school. But I can't be a cardiologist next year. And guess what? I can't tell Aetna and Blue Cross, hey, this year in 2024, I'm going to be a cardiologist, so I want you to pay me the specialty rates. Nah, Aetna's going to be like, hold on, what is your board training in? Internal medicine? Okay, yeah, we're going to pay you that way. Like, I can't do that. So, like, if you had to pick something that where, like, the doctors may, like, feel like a little bit of towards the mid-level providers, like, I think that is probably a big thing more than anything else. Let's see here. Perfect. Dr. Bates, since you are a DO, do you apply any visceral work to your patients? Oh, this is a very good question. So we can definitely talk about it. So as an osteopathic physician, DO, a part of our training during our medical school years is osteopathic manipulation. That was and that's why when I did outpatient medicine, one of the things I love doing. Now, I don't do a lot of it in the hospital setting. Not that you can't do osteopathic manipulation in the hospital setting. It's just, it just doesn't occur as frequently. And I think more importantly, yeah, and y'all probably already know where I'm going with this. I don't think docs realize how to properly bill for it as efficiently as you can do in the outpatient setting. So I think that's another reason why. But again, you didn't hear from me. You did not hear that from me. But that's what I'm thinking. But so I don't do it a lot. I typically do it more like with family, more the orthopedic ablation. I love it because it definitely works, right? I'm a big fan of it. Let's see. Let's see here. This is a good one. Shot Angel. I'm not sure if you're an NP or you just really love NPs. I think you actually said you love NPs. Doctors talk at you for 5 minutes and send you a huge bill. They do not address concerns like PAs and NPs. So let's knock out this misconception right off the bat, right? The second anybody goes to speak to you, whether it be a doctor, whether it be the mid-level providers, right? Guess who they're billing, right? They're going to bill your insurance, right? And they usually bill it under a physician, right? It's usually billed right under physician, right? It's sometimes there's a percentage difference that's there, but it usually a physician gets cut up right off the top. But again, I think it may be just personal experience. I think it may be personal experience of the doctors that you may have ran into. Because again, like I said, the same way, I can say that same exact statement for NPs. Yeah, NPs and PAs, they just talk at you for like a couple minutes and then they bill you. But the doctors take like that same general statement could be made if you made it in reverse. But I think there's this, and again, it may be good marketing, right? So let me tell you a good marketing thing for DOs, right? So again, shout out to the DOs. One of the good marketing things for DOs is that because we practice osteopathic medicine, is that we're more holistic than our MDs. And because we're more holistic, we listen more and, we provide different alternatives, which is true. But it's not to say that all MDs are like that. I mean, all DOs are like that, but it's a good marketing tool. So when you have this marketing tool as, all right, how can I, let the public feel that they should be just as comfortable with nurse practitioners and physician assistants, even though we know they have less training. Let me flip it and say, hey, you know what? If you want someone who's going to talk to you, guess who's going to do it? It's going to be a nurse practitioner and the PA. That doctor, he's going to be in and out, boom, boom, in out the room. So I think it's a very good marketing that doctors talk to you or don't look at you or do one of these things here, but the NPs and PAs don't. I think it's just good marketing more than anything else. Now, again, I give it up to them, right? They got that marketing down packed. But I think it is something that, we definitely need to touch on for sure. Dr. Keisha. I'll make sure I didn't know Dr. Keisha's on TikTok. I gotta make sure. Let me make sure I'm following you first. Let me see. I'll make sure I follow you after. There are rules for a reason. We need to acknowledge that scope creep is becoming a real issue. Yes, and that's a whole nother discussion, right? When we talk about the mid-level providers, because in their onus that they figure, hey, once I've done the work, right, become an NP, become a PA, and I've done it for a few years. Hey, give me more responsibilities. Like, why do I need a supervisor to do this? Why do I need a supervisor to do that? And this is one thing that I've always gotten upset at my physician colleagues is that from a political standpoint, we are so bad. Like we don't lobby well. We don't put our money to the lobbying. But guess who does? The nurse practitioners, the PAs. Which is the reason why a lot of them can do stuff, unsupervised now. Because they said, hey, we don't need doctors to supervise us. We're good here. So you now have this route where you have a nurse practitioner who is able to, again, bypass medical school, residencies, all of the boards, and now they can open up their own practice because their governing body has lobbied enough to the point where they don't need physicians, even though historically it has always been that way. So scope creep is a big is a big issue, right? So again, and that's where, for example, so I know Heather asked the question, what is scope creep? Think about let's say gastroenterologist. Let's say you're a gastroenterologist. And as a gastroenterologist, there's certain people who are able to do colonoscopies. But now let's say you're a nurse practitioner, you just got out of school, and you've been practicing, let's say your first job is with a gastroenterologist, and you start saying, hey, you know what? I'm good with my hands. Like, why can't I do the colonoscopies? Right? Like, why can't I do it? So now you start saying, hey, you know what? I don't need a gastroenterologist to do my colonoscopies. I'm going to do the colonoscopies myself. So now you're having certain, procedures, certain rules, certain things that used to be like, no, you have to have this level of training. Now, again, because of lobbying, they're able to fight and pull away and tease away at that. So I think, Dr. Keisha says it best. And again, I need to make sure I'm following Dr. Keisha. All right, perfect. I got the follow. I think Dr. Keisha says it best. Like it's a definite concern as a physician. And again, and that's really where the discussion should be at. Why is the system allowing it to a point where you can have less training? Because it is, you can have less training and then still be able to do the things that if I wanted to start doing colonoscopies tomorrow in the hospital, you know what my hospital would be like? They're like, Dr. Pierre, like, how many colonoscopies have you done? Like, nah, you got to do blank. You got to do a certain number of colonoscopies before we even sign off. Whereas you may have someone who they may be able to go to a school, right, that says, all right, yeah, you just do a whole bunch of colonoscopies. Hey, yep, I got signed off on them. Now I can do it myself. So definitely of concern for sure. Well, let's see here. Oh, perfect. Oh, let me see. So the anesthesiologist isn't usually the one at the head during surgery. It's the CRNA, right? So again, and this is what I kind of mentioned when I talked about the best example of the anesthesiologist, right? In terms of specialties who may be of concern, right? That, being a specialist, right? Being an anesthesiologist is not enough. Now, again, is that the fault of the CRNA? No. They're just doing what they need to do. Oh, where's my glass? They're just doing what they need to do, right? They see an opportunity. It pays very well. The hospitals see an opportunity because guess what? The price for a anesthesiologist, I'm just shooting a random number. Let's say it's $300,000. Let's say it's $300,000 annual salary for an anesthesiologist. But for a CRNA, let's say it's only $150. I don't know what they get paid. No matter. Which means that, hey, you know what? I can get 2 CRNAs for the price of one anesthesiologist. If you're a business, you start thinking like, hey, you know what? Do we even need anesthesiologists? So again, right, boom, scope creep occurs, right? Because now the system says, hey, you know what? I'm going to go ahead and pay these 2 people over here and replace you. You go find something else to do. Anesthesiologists who went to residency and medical school and back, like you go do that and pass all your boards. You go do something else. I'm going after the dollar bill. I'm going after the dollar bill because I know that now I done saved so much money, right? That I'm going to make billions a quarter, and then I'm going to have you anesthesiologists blaming the CRNA and not blaming Tenet, not blaming HCA, not blaming Blue Cross and Blue Shield, not blaming Humana. Like it's a dirty game that they got us, right? They really got us arguing over the pennies when the decisions that being made up top from a political standpoint, from a business standpoint, is really causing all of this issue there. Let's see. Let's see. Oh, let's see. Oh, who is, Gardner says, who is doing the hiring, allowing them to jump from specialty to specialty? I'm not sure if you're, I guess I'm assuming you're talking about NPs again. And who's doing the hiring? I'm assuming you're talking about businesses. And again, I think we might be talking in circles again. I already told you that if you're NP, right? Because I don't know if you're NP. Sound like you're NP. If the business says, hey, I can get paid more for going to another specialty next year, why wouldn't you do it? Right? Because nothing's blocking you from doing it. Why wouldn't you do it? You'd be crazy. You'd be crazy to do it. Just the same way when during this pandemic, when you were an RN, and guess what? If I become a travel RN, you mean to tell me I can get paid twice as much, maybe 3 times as much for doing the same thing I'm doing? Guess what you're going to do? You're going to become, if you have the ability, you're going to become a travel RN, right? So I think it's just, a business, right? And again, I'm not sure if Miss Angel, I don't know if your concern, right, is that it's the physician's fault that we're in the position that we're in. But trust me, you don't have to preach to me. I know that as physicians, we got to take some of this blame that's why I kind of mentioned the fact that when it came to being on the political table, we were not there. When it came to look for certain specialties, maybe looking out for their own personal gain and not really caring about other specialties, like that happened. Let's see. So, this is a good one, right? So I think the more rural areas utilize NPs at a higher rate than the specialty areas of healthcare. Yeah, and guess why? Because if you are a healthcare professional, right, especially if you're a physician, those rural areas might not pay you the amount of money that a big city pays you. So guess what these states do? These states say, hey, you know what? We can't even get doctors to come out to take care of our patients in our city. Guess what? We need some type of legislation to allow NPs to set up their own shop over there. Because if we don't, our patient's not going to get taken care of. But again, no one's blaming the NP for making the business decision. No one's blaming the doctor for making the business decision. The question we got to be thinking about is, how did it get to the point where that was a viable business decision? Why is it that medical school, residency, why is it that all of our costs to become a doctor cost so much money that we start making decisions like, you know what, I'm not going to do internal medicine. I'm not going to do pediatrics. I'm not going to do family medicine because it don't pay enough and I got all of these student loans. Right? And again, because the nurse practitioners and PAs don't have to go to that much schooling, which means their route to become that position costs less, they don't have to, finances isn't that big of a barrier for them that it is for the doctors, right? But again, we're not blaming the nurse practitioners and the doctors for making the business decision. We're blaming the system that has gotten to the point to that we had to make that business decision, right? Because that's really where it's at. Let's see. Oh, see, Dr. Keisha, for those who don't know, Dr. Keisha, I believe is they'll kill me. I feel like I think you're triple board certified pathologist. I believe she's triple. I believe she maybe double, but I think it's triple. Triple board certified pathologist, right? Would you want someone with less training diagnosing your cancer? And that's really what it is. Like if you ask, and again, now we're talking to the general public. If you ask the general public, who would you rather stand at the head of the bed when I'm getting surgery? They're not going to say a nurse. Let's just be real. If you ask the general public, who would you rather looking at the slides to let me know whether I have cancer or not, they're not saying a nurse or a PA. Like we could be, I hope we can at least be honest about that, y'all. Like I hope we can at least be honest with that fact. That you can't go and say, nah, I would much rather have a nurse practitioner be the one to say whether I have cancer or not, and then decide my treatment. I would much rather have a PA decide, the type of medicine I get when I'm going under for this heart surgery for my loved one. Like, if you ask the general public, y'all know what the answer is. And this is sometimes where it becomes disingenuous, is that people be acting like the general public would humbly say, like, nah. Nurse practitioner, PA versus doctor, no difference. Like that is where that's where it's like, all right, come on, guys. Like we're not even being genuine right now, because y'all know what the answer is. Y'all don't have to say it in the comments, right? But y'all know what the answer is. Y'all know if you ask your loved ones, hey, who do you want to diagnose me with cancer? And if I tell you, yeah, it's this nurse who went to school in Florida. You already know how the Florida nurse is going now. I went to school in Florida, And by the way, and then, they rounded at a couple of docs around the Palm Beach County area. And then they did another schooling. They become an NP and they pass the boards. Now, I'd rather have that person diagnosed with cancer than the person who went to undergrad, medical school, residency, multiple boards. Like, let's be real. Like, we don't have to do that. But again, that's how they get us, right? Because they get us having to argue those type of semantics. Like, it's not Aetna, Blue Cross, right? It's not the state of Florida, the state of New York, the state of Texas. It's not like the politics. It's not those people who are really driving these decisions here. Shout out to Dr. Sharon. And if you're a doc on here, please let me know, because I always follow docs on here. Dr. Sharon Smith says NP can be online with 500 hours of training. Lordy. Now again, if someone told you that your doctor, and again, in fact, I love this example, right? Because of COVID, I had a lot of medical students who did not have the ability to round at hospitals. I have a lot of medical students who did not have the ability to do the type of clinical work that they were used to doing. Do you know what the general public started saying? Oh, I don't want no doctor who ain't seen nobody. I ain't want no doctor who didn't touch nobody. Like, that was the general public saying, oh, those doctors, I don't know about that. Like, that's what they were saying. So so again, this is just, again, one of those instances. And again, I love that, Dr. Sharon. So Dr. Sharon says, I have done over 16,000 hours of training residency. We should not be having a discussion on who would you rather have in regards to Dr. Sharon's specialty. That should not, if we're being genuine, that is not a discussion that we should be having. Right? Like, it just is what it is. But when you have us fighting over the scraps that the systems, the hospitals, and everyone else has left over us, this is how we get into these debates where you may have a nurse practitioner talking about how the internists are like at the bottom of the totem pole, as if they are above that totem pole. Like that, I think that was what was more funny to me than anything else, right? Like, I'm listening to a person who is talking about my specialty being at the bottom of the totem pole as if they're above me on that totem pole. Like that was just too comical more than anything else. Let's see. Let's see if we got any more. Someone said, I wish you go live. We could definitely, because I've already been talking for hours, so we probably won't do it tonight. But I would love to have a conversation. Like I said, and I hate that nurse practitioner who made that video, like her account's gone. Like I said, hopefully she just temporarily deactivated. I would love to have a conversation with her, right? And again, honestly, I'm pretty sure I already know what she's feeling, because when it's not like it's not like she was live when she said it. She saw the comment, press record, talked what she needed to talk, probably threw some captions on it, and put a little caption at the end. So, there's a lot of steps to get to the point where that video comes out. So we kind of know what she's feeling. But again, I love to have this conversation, because again, it is something that I think is important for sure. Guardian Angel. Let me see. So and now obviously this is more of a, do you realize that people are losing faith in the healthcare system and are coming here for help? I'm not sure where here is, but again, there's a lot of reasons why they may be losing faith, but it ain't. Trust me, it ain't because doctors and nurse practitioners and PAs, right? There's a lot of different reasons why they may be losing some faith. Lots of different reasons, to go in that aspect there, for sure, right? But, so I definitely, again, before I end this, I want folks to know, right? This is not Dr. Berry hates NPs, because again, Dr. Berry not only loves NPs, he trains with NPs, he works with NPs. We love them, right? But what we want you to do, and again, it's not all y'all, but it's the ones that do it. don't do that. Like, don't step over a line where you start feeling yourself to a point where you kind of forget, like, your purpose, right? Like, don't do that. That's all we're asking for. Like, again, doctors, NPs, PAs, we got our own issues we got to deal with within our family. And again, don't let the public in our business. Don't let the public, don't be telling family business out on this social media, right? And then having to like battle for it, right? Like, don't do that. Ready to go. Oh yeah. So Angel, I'm not again. Angel, I apologize if you've had, because it sounds like you've had very bad experiences with the healthcare system. I feel your pain. I acknowledge, right, that a lot of people have had bad experiences. I hope that doesn't deter you away to the point where, you allow things that may fester, may grow, may become an issue later on down the line. Don't run away from us. Like, we acknowledge we got our issues, we got our concerns, and we're going to get that taken care of. All right. So again, I am about to hop off of here. The live will be posted on our YouTube page tomorrow. Hope, as long as TikTok doesn't play any games, we'll be posted on our TikTok page tomorrow. On our YouTube page tomorrow. Make sure you follow me on TikTok. Make sure you subscribe to the YouTube page. Link is in the bio. Like I said, very great discussion tonight. Very great discussion. So y'all be blessed. Y'all have a great evening. And just remember, right, like, we love our mid-level providers as a doctor. We love our mid-level providers. But y'all don't, to elevate yourself, you don't have to shit on us. Like if I could end it there, you don't have to do that. So y'all be blessed. Y'all have a good one. Bye.